Let's bypass the basics and jump immediately into the clinical material. We're strictly evaluating the intricate mechanisms, absolute contraindications, and precise management steps you need to confidently cross that 270 plus scoring threshold. It is all about absolute precision today. We're kicking things off with the portal hypertension marker, the serum ascites albumin gradient, or SAG. The diagnostic threshold here is an absolute hard line. A SAG value of 1.1 grams per deciliter or higher, that strictly isolates portal hypertensive etiologies, like cirrhosis or right heart failure. But if that gradient dips below 1.1, you have to immediately shift gears and evaluate for non-portal causes. Think nephrotic syndrome, malignant ascites, or tuberculosis. Staying with cirrhotic ascites for a second, let's look at the infection threshold for spontaneous bacterial peritonitis. The non-negotiable diagnostic mandate is an acidic fluid neutrophil count of 250 cells per cubic millimeter or greater. The exact second you hit that number, immediate empiric coverage is required. You're pushing IV cefotoxim for that enteric gram-negative coverage. But here is the critical, absolute must-do step. Albumin has to be administered concurrently, otherwise you are risking catastrophic hepatorenal syndrome. Now, let's contrast monomicrobial SBP against secondary peritonitis. This is a massive clinical trap. SBP is typically driven by a single organism, usually E. coli, right? Secondary peritonitis, on the other hand, often from something like a perforated viscus, features multiple organisms on the gram stain and a total acidic protein over 1 gram per deciliter. Recognizing that difference is literally life-saving because secondary peritonitis strictly mandates an emergent laparotomy. Antibiotics alone just won't cut it. Moving on to the cardiopulmonary system, we need to map the precise transition from a submassive to a massive pulmonary embolism. The crucial distinction here is understanding exactly what makes a PE quote-unquote massive. It is not defined by the sheer anatomical size of the clot itself. Instead, it's defined entirely by the hemodynamic collapse. We are strictly looking for sustained systemic hypotension, specifically a systolic blood pressure under 90 millimeters of mercury that's actively driving catastrophic right ventricular failure. Think about the hemodynamic choke point of a massive saddle embolus, completely obstructing the main pulmonary artery. In an instant, the right ventricle is forced to pump against a massive, fixed resistance. That leads to acute dilation, severe ischemia, and ultimately complete right heart failure. The electrocardiographic signature of this event is absolutely key. Now, while that classic S1Q3T3 pattern is widely taught, it's actually incredibly rare. The most common finding is strictly sinus tachycardia. But to operate at the highest clinical level, you have to actively hunt for signs of right heart strain. You're looking for a new onset right bundle branch block or T-wave inversions, specifically in leads V1 through V4. Let's isolate the treatment variable here. A hemodynamically stable PE strictly requires immediate anticoagulation. You're thinking continuous unfractionated heparin or a DOAC. Conversely, a massive PE presenting with severe hypotension strictly mandates systemic thrombolysis like alteplase. But, and this is a huge but, this is only true if there are absolutely no contraindications. If your patient had recent surgery, major trauma, or a prior hemorrhagic stroke, systemic thrombolysis is completely off the table. In those cases, you're mandated to go with surgical or catheter-directed embolectomy. Let's shift into our third module, sarcoidosis and extrapulmonary granulomas. The hallmark of this systemic disease is non-caseating destruction, most commonly manifesting as bilateral hilar lymphadenopathy. The biochemical matrix behind this is fascinating. Macrophages trapped within these granulomas actually autonomously express 1-alpha hydroxylase. That enzyme aberrantly converts vitamin D into its active form, which intensely drives symptomatic hypercalcemia and hypercalciuria. You also need to instantly recognize the systemic markers. Extrapulmonary targets are extremely high yield and strictly include anterior uveitis, which demands a slit lamp exam, erythema nodosum showing up as painful shin nodules, and Bell's palsy affecting cranial nerve 7. It's vital to contrast this with tuberculosis, since both can cause hilar adenopathy. The clinical variance is stark. Sarcoidosis granulomas are strictly non-caseating, and they come paired with elevated ACE levels and that hypercalcemia we just talked about. TB granulomas, however, strictly exhibit central caseating necrosis and bring severe constitutional symptoms. Think profound fever, drenching night sweats, and hemoptysis. Okay, let's integrate all these systems into a single massive master case. We're layering compounding complications here to really stress test your diagnostic and interventional precision. Multi-system hemodynamic collapse. So here's the clinical scenario. You've got a 62-year-old male with a history of severe idiopathic pulmonary fibrosis and chronic right heart failure. He rolls into the ED with sudden onset crushing substernal chest pain, extreme dyspnea, and lightheadedness. His heart rate is screaming at 132 and his blood pressure is a terrifying 78/40. O2 sat is 82% on a 15-liter non-rebreather. His physical exam shows profound jugular venous distension up to the angle of the mandible, a loud P2 and a harsh systolic murmur. And crucially, do not miss this, exactly 10 days ago he underwent a craniotomy to evacuate a subdural hematoma. His ECG reveals sinus tachycardia with a prominent S wave in lead I, a Q wave and inverted T wave in lead 3, and new T wave inversions in V1 through V4. A bedside echo confirms a severely dilated right ventricle that is literally bowing the interventricular septum into the left ventricle, even though his LV ejection fraction is preserved at 65%. His labs objectively confirm the severe strain. Troponin I is significantly elevated at 2.4, and his BNP is 850. We are looking at a patient in profound, catastrophic obstructive shock. Given these hemodynamics and his highly specific surgical history, which of the following is the single most appropriate, immediate, definitive intervention to prevent mortality? You have 5 distinct answer choices. Is it A, intravenous alteplase, B, continuous unfractionated heparin, C, emergent surgical pulmonary embolectomy, D, an IVC filter, or E, intravenous dobutamine and aggressive normal saline? Let's systematically break this down, starting with choice E, aggressive normal saline. This is a highly lethal trap. In a massive PE, that right ventricle is already completely failing against a fixed obstruction. It's massively overdistended. Pumping more fluid volume into that dilated RV will severely worsen the septal bowing. That physically compresses and further collapses the left ventricle, which catastrophically worsens the fatal drop in cardiac output. Aggressive saline will literally kill this patient. Next up, choice A, intravenous alteplase. Now, under normal circumstances, this is the absolute standard of care for a massive PE with hemodynamic instability. But remember that craniotomy 10 days ago? That acts as an absolute, non-negotiable contraindication to systemic thrombolysis. Giving alteplase here carries a near certain risk of a fatal intracranial hemorrhage, so choice A is strictly out. What about choices B and D, heparin and an IVC filter? While both of these interventions are absolutely vital to prevent clot propagation or stop new emboli from traveling up from the deep veins, they are entirely insufficient for the immediate crisis at hand. They don't actively lyse or remove the existing massive obstruction that is actively causing this right ventricular collapse. Therefore, choice C is the strict clinical mandate. With systemic thrombolysis absolutely contraindicated due to his recent neurosurgery, an emergent surgical or catheter-directed pulmonary embolectomy is the definitive, life-saving intervention required to reverse this fatal obstruction. Mastering high-level clinical scenarios isn't just about knowing the standard algorithm. It's about instantly recognizing the absolute contraindications that force you to abandon standard therapy. So the final question you always have to ask yourself, are you actively hunting for the traps in your patient's history before you prescribe the obvious treatment?